At the outset, let me thank Dr. Jithin sir as well as extracorporeal group for this opportunity. I would like to congratulate Dr. Vilesh for that wonderful presentation. And today I will be discussing on a rare case of tuberculosis post-renal transplant, which we encountered 2 weeks back. The story goes like this. So this is a 59-year-old gentleman who had transplant done in 2023 with wife as donor. And his native kidney disease was diabetic, probably diabetic nephropathy. He had comorbidities like hypertension, diabetes, and hypothyroidism. And he had induction with basiliximab and followed by triple immunosuppressive therapy. And post-transplant course was relatively uneventful. And he achieved a NADI creatinine of around 1.2 at the end of 2 weeks and was discharged subsequently. And further, his baseline creatinine remained around 1.4 gram per deciliter. There were no major episodes of rejections or infections. And now he presented to us with complaints of dysphagia and significant weight loss of around 10 kg for the past 1 month. And he noted dysphagia to both solids and liquids, slightly more than solids. And he had episodes of cough which was triggered after this food intake. And he denies any history of any fever or denophagia, hoarseness, any other neurological or systemic symptoms. And for these symptoms, he showed a ENT surgeon, and they did a endoscopy, and this was unremarkable. So on examination, the patient was conscious, alert, and oriented. And then examination was unremarkable. There is no lymphadenopathy, no oral ulcers, rash, and the respiratory system was within normal limits. And neurological examination, there were no cranial palsies or any muscle wasting. On investigations, this blood workup was essentially normal except for a mild elevation in transaminases and a creatinine value of 1.5 and the CRP levels, which was 80.5. So with these symptoms, since he complained of this odinophagia, a gastromedicine consultation was sought, and he underwent a upper GI scopy on the same day. And this is what the biopsy shows. So there's, you can see there's an ulcer in the esophagus with a fistula and probably a tracheoesophageal fistula and probable viral or fungal etiology. Now, to confirm this, we proceeded with a HRCT thorax. Now, this shows a circumferential wall thickening of the esophagus at the level of carina down for a length of approximately 5 centimeters from D5 to D8 level. And again, a defect was noted in the anterolateral wall of the esophagus at 2 o'clock position, which was communicating with the left distal bronchus at around 3.8 centimeters from the carina. So this is the CT images. So you can see that this is the fistula which is communicating with the bronchus. This is a Riles tube in situ. So that's a fistula which is communicating, and there's few lymph nodes and a mild peribronchial infiltrates in the left lower lobe. So again, this fistulous communication between the esophagus and the bronchus. So finally, the diagnosis was a bronchoesophageal fistula in a renal graft recipient. The etiology again could be viral, fungal, tuberculosis, or malignancy. So immediately, the immediate management, the patient had difficulty for having food, episodes of coughing and breathlessness. And so he was immediately started on broad-spectrum antibiotics to treat the aspiration pneumonia. The patient was on everolimus, tacrolimus. The MMF was stopped earlier because of diarrheal episode. So this time, because of the fistula, and we stopped everolimus, and he was taken up for a therapeutic endoscopy on the next day, and a self-expanding metallic stent. So this is what is self-expanding. This is usually used for treatment of strictures as well as malignancy to keep the esophagus patent. So for this patient, since immediate surgical procedure was not possible, and we need to find out etiology to reduce the symptoms, we resorted to self-expanding metallic stent, and this was deployed with a covered stent. And the efficacy of the procedure was subsequently verified with a dye study. And following this, the patient was able to tolerate oral feeds after the procedure. So this was a stent, the metallic stent, which was deployed. And this is a dye study which should look in the patents. You can see the entire length of the metallic stent. And this is a metallic stent in place. And this was a dye study to check in patency and see if there's any leaking. So the dye study showed that there was no leak. So then we waited for the biopsy report. So biopsy again showed esophagus showed granulomatous inflammation with several AFB and ulceration, which was in tandem with tuberculosis infection. You can see the cascading granulomas and the AFB. The sputum gene expert also came as positive for mycobacterium tuberculosis. So the final diagnosis was bronchoesophageal fistula in a renal allograft recipient of tuberculosis etiology. So this is a rare tuberculosis, bronchoesophageal fistula causing due to tuberculosis. It's a rare condition following transplant. And he was started on anti-tuberculosis therapy, which included rifampicin-based regimen. And the dosage of tacrolimus was increased. And the further dose was adjusted based on the trough levels. Everolimus was stopped. But however, a week, 1.5 week later, after discharge, he had ATT-induced hepatitis. So we had to stop rifampicin and paracetamol and INH, and he was started on modified ATT. And tacrolimus levels were readjusted. His renal functions were normal during this time. And the liver functions gradually improved. And now we are planning to rechallenge him with lower doses. Thank you.
Thank you, Dr.